This meeting, specially called meeting of the Caldwell County Board of Education, is called to order here on August 16th, 2021. We want to thank you for being here. We want to thank you for the interest that you have shown in this matter. It's been very important to each of us up here. It's not something that any of us has taken lightly. It literally has been on my mind, and I think I can probably speak for the others on the board, been on my mind every waking hour. And you know, we certainly thank you for your emails. We have read emails. We have watched videos. We have read articles. You know, obviously there's been, you know, some discussion here and there. And there's been a lot of thinking and a lot of praying that's gone into this situation. It's been a very difficult time for each of us. And we want to do what is best for the children of Caldwell County. And this is one that is extremely difficult to deal with. You know, having been on the board for 11 years, I don't think I've come up against anything that has been as draining as this has been for me. And I'm sure it has been for each of the members on the board, and for that matter, Dr. Phipps as well. But again, we're glad that you're here. Our first item of business is approval of the agenda. Do I hear a motion that we approve the agenda as presented?
Chairman Penn will make a motion to approve the agenda as presented.
Is there a second?
Second.
All those in favor say aye. Aye. Any opposed? And that motion passes. And next item is, I'm going to pass it over to our superintendent, Dr. Don Phipps.
Thank you, Mr. Chairman. You all know that about a month ago we met and the decision was made to leave the masking piece as optional. And you asked me to take a look at what our data was locally as we got closer to students returning to school. And I've tried to keep you up to date with information locally and also from the state and national sources that we have, and felt the need just to reconvene the meeting to make sure that we're on the same page as we move forward. Regardless of the decision that's made, you certainly have my full support in implementing whatever needs to be done to work for our students and our staff members to make this school year successful. You all submitted questions that I've had an opportunity to have medical folks take a look at. I also tried to collect some data, and Dr. Lowry is here, and I wanted to ask Dr. Lowry, who's here representing the hospital. Anna Martin was not able to be here, but we've been in contact with her quite a bit through the health department, and we have their support, and I certainly don't want to speak for Dr. Lowry. Outcomes, there are multiple options that we can have, but I hope regardless of the outcome, Dr. Lowry, that we continue to be strong partners with the hospital and we work together to mitigate as much as we can and measure whatever threats there are without regard to whatever decision is made. But if you'd like to step up and share anything, you can. If you just want to be there to answer any questions that come up, you certainly can.
Well, thank you, Dr. Phipps, and members of the board. And I'm honored to be here and have an opportunity to speak with you all. And that being said, I know this is a very difficult question, and there is a wide range of opinions, and in some cases, conflicting advice from experts. And I want to approach this with humility. I'm here to just help as best I can, and our hospital and healthcare system is here to support the residents of Caldwell County. And that being said, I am just tickled pink to see all of you out here tonight. I know there are differences of opinion, but one thing I can say is I'm encouraged by your unity in the fact that you all care and are passionate. Regardless of how you feel about this particular topic, I can tell that each and every one of you took time out of a Monday evening to be here because you care and you want the best for children, you want the best for the residents of Caldwell County, and that is such an encouragement, and you all are to be commended for that. What I can say, just a brief overview, I am done with COVID. we have been dealing with this for a year and a half. I myself developed a COVID infection on New Year's Day, and it was pretty miserable. And having gone through the surge after Thanksgiving and having dealt with the impact on our community, seeing people die, feeling helpless in many situations to be able to provide the care that was needed, having to call for help from an international aid organization to have a field hospital put up in the hospital. When we finally got through that, it was such a relief. And then here we are. I feel like deja vu. I feel like this is early December of 2020. And that's the cold reality. As much as I want to change things, we're still here. So the question is, what do we do now and where are we right now? I can answer a couple things in terms of the local impact of COVID. As you know, it is surging. A month ago, we had one patient in the hospital at Caldwell with a COVID diagnosis. Now, at our peak on mid-January, there were about 49 patients with COVID in the hospital. And then the next day, it went to 0. That patient had been discharged. And for one day, we had no patients in the hospital with COVID. That was about a month ago. One of the things that we've been doing since late November is administering what are called monoclonal antibodies. Regeneron is the company that manufactures monoclonal antibodies, and this is an IV infusion that's given for patients who've been diagnosed with COVID who are at high risk for disease progression. And at our peak in December, we gave 12 doses on a single day about 3 or 4 times. And again, a month ago, we gave 1 dose for an entire week. That's it, 1 dose. Today, we gave 30 doses. Friday, we gave 26 doses. That's how bad and how quickly this has turned bad. I feel really like we are where we were in December, early December. Currently, there are 17 patients at Caldwell diagnosed with COVID in the inpatient setting. As far as our regional partners at Fry, Catawba Valley, Blue Ridge, Watauga, they're facing equivalent numbers. About 20% or so of the patients in the hospital are COVID positive at each of these hospitals, and beds are becoming short. So that's where we are right now. The surge is real. We're feeling it, and we're being impacted pretty significantly. And that is a brief overview. I could ramble on, but I think it's probably best if I stop at this point. I just wanted to give you a snapshot of where we're at. And again, commend you all for caring. I'm just so encouraged to see all of you here tonight. Thank you.
Anybody on the board have any questions that I'd like to ask Dr. Lowry? Would you say that this is much more contagious than what we were experiencing back in December?
Yes, sir, I would. The number or the term that's used is an R0 or an R0, and that term means the number of individuals that an infected individual will subsequently give the disease to. And in January, February, the R0 in North Carolina was around 2.0, 2.1. The R0 for the Delta strain or Delta variant is estimated to be 6.0, so roughly 3 times more infectious. So if I had an infection, I would be expected to spread it to 6 other individuals instead of 2. Now, the thing to remember, an infected individual is contagious for 48 hours before they develop symptoms. So oftentimes, a person who is infected and can spread this to others may have no idea that they have an infection. And a significant number of individuals are asymptomatic. In other words, they have the infection, but have no symptoms or very minimal symptoms, and they're contagious for up to 10 days.
Dr. Lowry, will you explain and talk about the fact that if you're wearing masks, the quarantine is one way, and if you're not wearing masks, if you're in a classroom with someone who is determined to be COVID-19, would you explain the difference,
Yes.
please?
So the question would be, how does wearing a mask affect quarantine? So that gets back to the degree of exposure. So if I'm exposed to someone who has a COVID infection, for example, we classify that as a low-risk exposure, a medium-risk exposure, or a high-risk exposure. So if one of us is if we're both wearing masks and we're around each other even for hours on end and we're both wearing masks, that's considered a low-risk exposure. And generally speaking, for a low-risk exposure, quarantine is not required. Self-monitoring is required. So if I'm with my friend and we're sitting together for 3 hours and he calls me later that day and says, oh my gosh, I developed a fever and I have COVID. If we both had our masks on, I would still be able to go about my normal activities. I would just keep an eye on myself. And if I developed a fever or sore throat or sinus congestion or whatever, I would go get tested. However, if one of us is not wearing a mask, at best that's considered a medium risk exposure, which would generally result in quarantine. Now there are some other mitigating factors, including vaccination status and such, but more than likely if one of us isn't wearing a mask, I would have to quarantine. And if neither of us are wearing a mask, that's considered a high risk exposure and is no ifs, ands, or buts, quarantine.
This is Dr. Lowry. I'm a little confused, which some people may not be understand that. But so if the Delta variant is 6 times more contagious, the original COVID, if you had a mask on no matter what, I mean, it really didn't matter. You were still quarantined. Or is that not right?
That's no. If both parties were wearing a mask, that was considered a low-risk exposure. The CDC and other health agencies considered that a low-risk exposure. So exposure is 15 minutes of unprotected exposure cumulative over 24 hours. So mask wear factors into quarantine and determining whether it was low, medium, or high-risk exposure.
And Chris, what we're following is in the Safe Schools Toolkit, which may be a little bit different in terms of how our nurses are implementing and what we call close contacts. And those would be individuals would have to be determined to be a close contact and then determine whether or not quarantine would be required.
Well, the only reason I brought that up, and personally, I had tested positive for COVID as well, and it was never asked whether I wore a mask or how I got it, or it was never. I was just curious as to how that comes
So
about.
the difference,
now.
if you tested positive and you had the disease, it would be kind of immaterial. The question would be for those to whom you were exposed, whether, so someone who works with you, for example, who once you tested positive, to answer whether they would need to be quarantined, it would be, that's where the question would come into play. So if they were wearing a mask and you were wearing a mask when they were around you, they would not have to quarantine.
I understand.
And it's different right now for students than it is for adults. For some reason, the latest update that we had on the toolkit treats students and adults differently when it comes to close contacts.
Dr. Lowry, we're one of 20 counties in the state that are identified as being at high risk of COVID-19. Will you talk about the dangers of that and how the medical professionals view that?
Sure. Caldwell County is a very high-risk area, and it directly relates to vaccination rates. I can tell you that this morning there were 17 inpatients at Caldwell. None of them had been vaccinated for COVID. Over the past week, cumulatively of probably 30 patients who've been admitted, all but about 3 were unvaccinated. So currently in North Carolina, the vaccination rate among adults is 58%. In nationwide, it's a little over 50%. In Caldwell County, it's 37%. So that poses a direct that directly correlates with the level of disease activity in the county.
Any other questions?
Dr. Lowry, we appreciate all the data that the hospital and the health department are working together to share on the health department's website. And there's one of the charts shows the cases among children birth to 18, and it's split up 0 to 5, 6 to 10, 11 to 18. Can you talk at all about the recent outbreaks in those areas?
Sure.
And what the numbers are?
Children are very likely to get a COVID infection. However, fortunately, most COVID infections in children are not severe, do not result in hospitalization. However, nationwide, since the beginning of the epidemic, nearly 400 children in the United States have died from COVID or complications thereof, which is 400 too many. One critical illness in a child, in my opinion, is one too many. That being said, last week, midweek in North Carolina, on a single day, there were 274 patients admitted to North Carolina hospitals with COVID infections. 2% were children under 17 or younger, so roughly 5 or 6. Doesn't sound like a lot, but that's 5 or 6 too many. Children have died in North Carolina from complications of COVID, not that many, but again, too many. The important thing to remember, though, is that children are a vector for disease spread. And even though not many children end up hospitalized at this point with critical illness, their parents do, their grandparents do, their caregivers do. So a child who may have pre-symptomatic disease to the point that they have no symptoms but are still highly infectious or contagious may go home and infect their 82-year-old grandmother, who will subsequently die. The risk of death correlates exponentially with age. So roughly speaking, a 100-year-old, and there are some people age 100 who have had COVID infections and have survived, but a 100-year-old is about 10,000 times more likely to die from COVID than a 20-year-old. The elderly or those who are immunocompromised, or the teacher or parent or caregiver or pastor of church or Sunday school teacher who is exposed to that child may gain and may become infected and subsequently develop critical illness or death. That being said, there are children who have died and have become critically ill.
So do you think our numbers here in Caldwell County are comparable to the state?
The county data would show that they are comparable. Again, the diseases, the hospitalized children tend to be in tertiary care centers in the major urban areas. For example, Levine Children's Hospital in Charlotte. We made a decision a year ago at Caldwell to transfer any child with COVID who needed inpatient care to a tertiary care center, just because of the unique nature of this disease and the potential for complications that would require very specialized care. So we have, at Caldwell, there have been no patients under age 18 who have been hospitalized with COVID, and that's why most of the data is coming out of Levine Children's Hospital or the tertiary care centers in the Triangle region.
Anyone else?
We followed quite a bit of the statistics that came out in the fall and into the winter about trends with respect to timeframes. What are the current trends suggesting in terms of peaks and what kind of
Sure.
dates and stuff?
So a year ago, the epidemiologists at UNC Health developed a prediction model, which they published diligently every week, and it was very accurate. It was based on factors multiple factors, one of which was the R naught that I mentioned earlier. And that helped guide us over the fall and through the winter. And around March, they stopped producing it. They said, hey, things are great, which was true at the time. Well, the model is back. And the latest model shows that we are looking at a increasing curve statewide with a peak that will occur in early October, and that will decrease over the winter and not really get back down to baseline excuse me, baseline values until late winter, early spring. The peak that we're looking at is somewhere at this point on the magnitude of about 80% what we experienced in January. So maybe not quite as high, but definitely high. That being said, this curve is updated weekly. And again, this takes into account North Carolina as a whole. We think that Caldwell County may be affected or impacted disproportionately because of the relatively low vaccination rate. And the trend predicted about 300 COVID-positive inpatients in UNC Health beds in early October. So including Rex Hospital, Caldwell, Pardee in Hendersonville, all of the UNC hospitals, about 300 beds. This morning we were at almost 240 already, which tells me that we're either peaking early or that the height of the peak will be higher than expected. And again, that has to do with the fact that this particular strain is highly contagious and the lower than desired vaccination rates.
Anything else?
Yes, sir. So, it was about a year ago this time we had to choose plan A, B, or C, which you may remember that, you may not. So we've been through a lot of decisions along with help and guidance. I guess my question is, and I don't think that you can answer this, and I hope you can, but wearing masks outside of school versus wearing masks in school, obviously, I guess if you wear it at any point, it helps, but it's almost as if you're expecting these, not you, but people are expecting the children to stay in wherever after school and do all of that. So what is your thoughts on?
Yeah, these are tough questions. And it's all about risk mitigation, not risk elimination. So the question would be, do people who wear seatbelts ever die in car crashes? Yes, they do. But we do know that seatbelts and child car seats eliminate a lot of the risk involved in automobile accidents. So, for example, your question would be, a child wears a mask at school, but then they go home and are exposed to a lot of people and don't wear a mask. Does that pose risk? Yes, it does. But does wearing masks in close quarters when there are a lot of different exposures help mitigate or reduce that risk? Yes, it does. It doesn't eliminate it by any means. And mask use is just one of several strategies that all should be deployed. If I'm going to play football, I'm going to wear a helmet, but I'm not a football player. I stopped playing football in 8th grade when everybody else got it. But if I were playing football, I wouldn't stop at a helmet. I'd put on my shoulder pads and hip girdle pads and my knee pads and my cleats and all that for protection. So I'd take a multi-phased approach, which really is what the North Carolina toolkit is suggesting.
Thank you.
Anything else?
I do have one additional question. The compromised children that we have, and we want face-to-face learning. Talk to me about those children and the effects and the possibilities of getting COVID.
So immune-compromised children, Yes, so anyone who is immune compromised is at risk for severe disease and complications, and including children who are immune compromised. And ideally, someone who has an immune compromising condition would be identified, that would be known to them, and their caregivers would be able to identify those people or those children and take appropriate precautionary actions. Sometimes people are immunocompromised and they don't know it. So, for example, hypothetically, a child who maybe is in the early stages of acute lymphocytic leukemia, which is a curable form of childhood leukemia, may have a low white blood cell count and be immunocompromised, yet not yet be aware because the diagnosis has not been made. That's one of the concerns with this horrible infection, that sometimes people are at risk and they don't even know it.
Anything else?
I was going to ask Dr. Phipps if he would go through, I mean, as well as you can, the quarantine for schools.
I think, and I'm just looking at two options, just for sake of being able to explain things. If the board were to stay with the option of masks being optional versus if the board were to change and say that masks were mandated. From a student perspective, looking at the toolkit, if a child is not wearing a mask, then they're going to be quarantined if they're a close contact. If they're wearing a mask, they won't be if they're asymptomatic. So if there can be fewer quarantines. One of the concerns that I have is just going to be what our quarantine numbers are going to look like the first week or two of school. I have no way of predicting what that is. But we'll have to come back to the table and have that conversation if it looks like that we're in a situation where we're threatened to be able to open school and have teachers there, or if there are large numbers of students or whatnot. I mean, we dealt with that some last year, particularly as we got into November, December, January. And I have no doubt that we'll be talking about that again, but I have no idea to what level it would be. But we will have more students quarantined if masks are not mandated, and that's not a push one way or the other, it's just a fact.
But would it be an option if there's no changes and the numbers in one particular school or one grade level at a school rises to do something different just for that instead of doing an entire system-wide? Can it be done specific?
It can, and we talked about that, whether it was school closures, if we were limiting movement in a building, or if there had to be something done at a particular school in a grade level because the numbers were there. I'd rather do that if we could and manage and mitigate with a school and a small number than to do something that impacts the entire school district, unless there was some reason to believe that it was spilling over district-wide and we needed to do that. Any decision like that would be made would be with you all informed, but also with the medical folks at the table with us to take a look at what their data looks like. And I just feel like having more eyes and different perspectives on it allows us to have a clearer picture of what ultimately needs to be done.
Well, from our conversation, you had told or said that children who ride the bus by federal mandate, they have to wear a mask. So that's not a choice.
That's a federal executive order unless something has changed that I'm not aware of. And a federal executive order trumps anything we do locally or statewide.
Okay. So going back to where you were talking about trying to do something within the system, could it be that if nothing changes, we leave the vote just as it is? But we need to do something different. I mean, could it be the optional mask for that particular grade level, or whatever group it is that we see that there's an issue? It could be that, this school has to wear a mask because this number is rising rapidly in this school, or this grade level if it's a high school or middle school, or I guess even in elementary school.
And I think we can consider all of those restrictive measures that we need to go to and have those conversations when the time comes, yes.
Any other questions? I think we can say that Dr. Phipps and his team here have worked tirelessly for the last 18 months. It's been a very difficult time for not only the board, but certainly on a daily basis for Dr. Phipps and the people that he's been working with. And he's been getting advice from a variety of sources. So we truly do appreciate the great job that he has done. That being said, as chairman, I cannot make a motion, nor can I second a motion. So, we have a motion.
Chairman Pennell, because I so believe in in-person learning and the safety of our children, I do move that we adopt a mask mandate for our system.
An N95 mask, unless you issue that to all the kids, a mask mandate is useless.
Okay, do we have
Every
a
person over there
second?
must touch their mask
Do we
15
have a
times
second to that motion?
in the past 30 minutes. You don't think our kids are going to touch their
Do
masks?
we have a second to that motion?
No.
Okay, let us proceed and we'll
are wearing masks, right this second.
do we
Nobody
have a
here.
second?
Don't wear a mask.
Why have you not got a mask on?
Doctor
Yeah.
himself doesn't even wear a
Guys,
mask.
let the process
Yeah, let
happen.
them-
Let the
vote.
process
Let's
happen.
do
Let us
Let's
get through the process.
Let's get through the process.
Is there a second?
Can I ask the doctor some questions?
Well, it's not really appropriate
Let him ask.
situation.
Let him ask.
Let him ask it. He has the right. He's an American.
Absolutely.
We have right now, just a minute. We have a motion on the floor. Let's get through this, and then you can ask, okay? We don't mind you doing that. For lack of a second, the board will fall back to its previous decision of the mask being optional.
Thank you. Now, you want to ask a question?
Excuse me, I properly submitted a request for public commentary and was denied that request.
Yeah, so was I.
Yeah, we all were.
We were That's fine, but if one person is going to have that opportunity, then everyone who submitted a request should have that opportunity.
Okay, then in that case, and as per the rules of a specially called meeting, we do not have any special comment or open comment. If you have a question, you can speak with Dr. Lowry once we adjourn. Okay?
Awesome.
But that was the way we came in here, and we knew that that was the rule, and there was not going to be any open comment. And without a second, we revert back to the previous decision, which is that we remain currently with the optional approach, and Dr. Phipps and his staff, in conjunction with the medical people and the others that he has been talking to, will be keeping up with it on a daily basis. That being said, do I hear a motion we adjourn? Is there a second?
Second.
This goes against Caldwell.
All those in favor say aye.
Aye.
We are adjourned.
Aye.